Hi, and welcome to RadOnc Talks, a lecture series designed for students and residents of radiation oncology. My name is Ria. I am currently a PGY5 resident at the University of Pittsburgh, and today we'll be continuing in our high-yield physics review with the topic that was actually requested to me on properties of electron beams. I've started to try to record some videos on physics basics. And previously I recorded a lecture on some basics of photon beams. Once again, I am no expert in physics, but what I did realize when I was preparing for my physics board exams is that the easiest way for me to remember these sometimes complicated concepts is to really think about how they actually apply in our clinical management of patients and how we incorporate these concepts into our treatment planning. And when I, learned it that way, and when I tried to apply it in a way that was really clinically relevant, that is really when it clicked for me, and that's when the material started to make sense. So my hope in this talk is to kind of go through some basic properties of electron beams, and then at the end we'll actually walk through an example case of treating a skin cancer with electrons and try to apply some of these concepts that often come up in our testing, just so you can see how it's really important and relevant in practice. So let's start by talking about how electron treatments are delivered. And remember that we deliver electron therapy using the same linear accelerator that we would use to deliver photon therapy. In a linear accelerator, what we have are a bunch of electrons that are accelerated towards a heavy metal target, usually a tungsten target. And when they interact with that target, they undergo a reaction called Bremsstrahlung. And that is kind of a braking radiation. And that Bremsstrahlung interaction causes the electrons to kind of curve around the heavy nucleus of that heavy metal target. And in the process, some energy is lost and it's actually released in the form of photons, which are also X-rays. So X-rays are just photons that are produced extranuclearly. And those X-rays are then kind of angled through a series of different devices, including primary and secondary collimators, and they hit the patient. And that's how photon therapy is delivered to the patient. Electron therapy is delivered using the same linear accelerator that we used for X-ray therapy, except for electron therapy, we actually remove that tungsten target. So that tungsten target that causes the production of X-rays via Bremsstrahlung radiation, it's moved out of the way, so the same electron beam that's accelerated from the linear accelerator continues to sort of shoot through in a very linear fashion. In an X-ray machine, so when we're delivering with photons, remember that we usually have a flattening filter in place, and that helps to create kind of a more homogeneous horizontal dose distribution from the photon beam. There's usually a carousel that replaces the flattening filter for something called a scattering foil. And the scattering foil helps us to take that very linear electron beam and kind of spread out the beam to create a more uniform dose distribution. So for electrons, we need to hit a scattering foil. And then the electrons are going to go through the machine, and we usually apply something called an electron applicator or a cone. It's kind of an accessory mount that we apply, and it helps us to collimate the electron beam to our specific size and shape of the field. So whenever we're treating something, we typically measure our field. So it's usually the tumor with usually around a 2 centimeter extra margin on either side. And that helps us to determine what our field size is going to be. And then we actually will draw out what we want to treat and create a block that's in the shape of the area that we want to treat, which is usually the tumor with a few centimeter margin on that. So what we essentially do is draw the field that we want to treat, so the tumor with a little bit of a margin, and then we create a customizable lead cutout that allows the electrons to travel to the target, but then it blocks them out of the periphery where we don't want to treat. And so that applicator is kind of specifically designed for each patient, and it helps us to shape our electron beam to the shape of our target and prevents the excess spread of electrons. That mount is also kind of, it it comes out and it juts out from the bottom of our collimators. And what that does is it actually, brings the electrons closer to the patient's surface, and it minimizes the air gap between the head of our machine and then the patient. And that's important because when there's more air between the electrons and the patient, those electrons are very light, remember, and so they're going to kind of scatter. So we try to bring the applicator closer to the patient's surface and prevent as much scatter as we can in the air. So some of the key differences in the LINAC when we're delivering with electrons, remember, we're going to remove the X-ray target. We insert a scattering foil to help create a homogeneous dose distribution, and then we apply this electron applicator or electron cone to help collimate our electron beam to the specific size and shape of our target area, and it helps prevent the excess spread of electrons. Now that we understand how electrons are delivered, let's go back and review what electrons are, so some basic fundamentals. Remember, electrons are also called beta particles, and they are negatively charged particles, so they are considered directly ionizing because they have a charge. Photons, on the other hand, are uncharged, and they are indirectly ionizing because when photons interact with matter, they first have to go through some type of interaction, such as Compton scattering, most likely at the energies we use in therapeutic radiation, and that process produces electrons that can then go and directly or indirectly damage DNA. When we're treating with electrons, we're already delivering that charged particle that can go and either directly or indirectly damage DNA. So electrons are considered directly ionizing particles. They are also different than photons because they have a resting mass energy, and this number is very important to memorize. The resting mass energy of electrons is 0.511 MeV, and pay attention to the units. So that's mega electron volts. They might trick you by asking in kilo electron volts, in which case it's 511 kilo electron volts. So just remember one. I always remember 0.511 MeV, and then you can convert it to the correct unit as needed. But electrons do have a resting mass energy of 0.511 MeV. This is a fairly low mass, but it still is some mass. So in contrast, our photons are massless, and protons, on the other hand, are 2,000 times heavier than electrons. So electrons have a mass, but they have a very, very, very low mass. So because of that mass, that kind of affects the physics of how these particles are going to travel through the body, right? Photons are massless, and so they typically travel all the way through the body, and they have both an entry dose as well as an exit dose. Electrons, on the other hand, are very light, but they do have a mass, and because they have such a low mass and they're so light, they don't travel very deep into the tissue. They tend to be very, very superficial, and thus they are used to treat superficial tumors. So they typically deposit all of their dose fairly superficially, on the order of a few centimeters. There's a rule of thumb to determine what the practical range of an electron is, and it's typically the energy divided by 2. So, for example, for a 9 MeV electron beam, the practical range would be 9 divided by 2, which is 4.5 centimeters. So 4.5 centimeters, when you compare it to photons, is really not a lot, and those act fairly superficially. And that's just the practical range of where we can actually clinically detect any dose. The therapeutic dose window is much narrower than even that 4.5 centimeters. So electrons deposit most of their dose extremely superficially, and that's why they're used to treat very superficial targets such as skin cancers. And again, this is very much in contrast to photons, which are massless and travel all the way through the body and have an exit dose. In my opinion, the most important physics concept to understand around electrons is their percent depth dose curve and how it differs from photons. And I think if you understand this, that is probably one of the most commonly asked questions when you're in a radiation oncology clinic. It does come up, I feel, on exams, and it's super important to understand this concept. So when we think about the percent depth dose curve, there are really two things that are probably the most important. So number one is the surface dose and what happens at the surface and how that differs with differing electron beam energies. And then the second most important thing is the depth of D max and where that depth of D max is and how that differs with different electron beam energies. So let's review from our discussion on photons. Remember, we talked about how the surface dose is lower at higher energies. So lower energy photons actually tend to have a higher surface dose. So there's kind of an inverse relationship there. The depth of D max is deeper at higher energies for photons. So if we use a lower energy photon beam, the hotspot is going to be more superficial compared to if we use a higher energy photon beam. So for photons, the surface dose is lower at higher energies, and the depth of D max is deeper at higher energies. Electrons are different than photons, and when it comes to the surface dose, they're actually the opposite. So whereas for photons, the surface dose is lower at higher energies, with electrons, the surface dose is actually higher at higher energies. So if you look at the image on the right-hand side, we have a 6, 12, and 20 MeV electron beam percent depth dose curve. And on these PDD curves, you can see that the red line, which represents a 20 MeV electron, it has the highest surface dose, which is higher than the 12 MeV, and then the 12 is higher than the 6 MeV. So for electrons, the surface dose is higher at higher energies. The depth of D max, however, is the same as what it is for photons. So the depth of D max is deeper with higher energies as well. So this, I think, is just the most critical concept to understand, and it's something that you just have to memorize. So remember that when we think about electrons and photons, the depth of D max relationships are the same. So for both electrons and photons, the depth of D max is deeper at higher energies. And I think if you think about it a little bit, it does make some sense, because basically the higher the energy of the photon or the electron, whatever type of radiation we're using, the higher the energy, the deeper it's going to travel. And so for both of them, the depth of D max is deeper at higher energies. For photons and electrons, the surface dose, however, the relationship between energy and surface dose is opposite. So for photons, the surface dose is lower at higher energies, whereas for electrons, the surface dose is higher at higher energies. And once again, if you really think about the mechanism, it does make sense, because remember with photons, we talked about how they are not directly ionizing, they are indirectly ionizing. So they first have to undergo a Compton interaction before there's enough buildup of electrons, before we establish that electronic equilibrium. So with photons, there's a buildup region once those photons hit the skin. And so the surface dose is lower at higher energies because that buildup region is greater for higher energies. With electrons, on the other hand, they are directly ionizing right off the bat, and so their surface dose is going to be higher at higher energies. They still have a buildup region before they get to that depth of D max, but they are still able to have a higher surface dose just since they are directly ionizing. So however you want to think about it, whether you remember the mechanism and try to really understand the physics of what's happening, or if you just remember that the D max for both is deeper at higher energies, but only for electrons, the surface dose is higher at higher energies, and then for photons, it's the opposite. Whatever you want to do, I think just really, really commit that to memory. And once you understand that most important concept, everything else, I think, makes more sense logically. So another concept for higher energy electron beams is this idea of range straggling. So basically, for higher energy electron beams, we see that the dose falls off less sharply. So if you look at the 6 MeV curve, the dose falls off very steeply, very sharply. The 12 MeV curve is more of a angle, and then the 20 MeV curve has a very huge slope, and it's much less steep. And this is due to a phenomenon known as range straggling. The reason that range straggling happens is sort of something we've already touched on. So we talked about how electron beams get degraded as they leave the linac and sort of travel through the patient. So we try to minimize that distance between the electrons and the patient by adding that electron applicator, also known as that cone, to kind of direct the electrons forward and prevent them from scattering in the air. But despite that, there's still a little bit of air between the electrons and the patient. And by the time they actually hit the patient's surface, some of those electrons have degraded and they are kind of polyenergetic. So it's not just the maximum energy that we're using. So say we're using 6 MeV electrons. By the time we hit the patient, there's a range, say from 0 to 6 MeV. And so these different energies result in different depths of penetration, also known as range straggling, and that causes, the dose to not all fall off at the exact same depth. As we get to higher and higher energies, so as we go from 6 to 12 to 20 MeV, the range of those polyenergetic electron beam energies is much greater, right? And so now we have many more energies that will have different depths of kind of their fall off. And so due to that, the higher the energy beam, the greater the range of polyenergetic electrons within that beam. And so the greater the range straggling that occurs due to those different fall offs for each of those different energies. So that's a little bit of a complicated thing to understand, but big takeaways here are that for electrons, the surface dose is higher at higher energies. The depth of Dmax is also deeper at higher energies. And higher energy beams are going to have more range straggling, meaning that the dose is going to fall off less steeply because there's a broader range of polyenergetic electrons hitting the patient. Once we sort of conceptually understand these principles of electron therapy and kind of these fundamentals of how electrons work and penetrate through a patient, I think that is more than half the battle, truly, is to just understand what we've just gone over. Then there are a few different equations that often come up and are tested. And these are also important equations to be aware of when we are going through an actual clinical setup and planning out how to treat a patient with electrons. So what I'd like to do is go through some of these formulas, some of these considerations, and then, like I said at the end, we will walk through an example case and kind of apply everything that we've talked about leading up to that case. So if you're going to remember any equations for electrons, I would remember these 4. These are known as kind of the electron, quote unquote, rules of thumb. And the mnemonic for these rules of thumb is 5, 4, 3, 2. And the mnemonic is very imperfect because the number 4 and the number 3, as we will see, are not 4 and 3, in fact, but they are slightly different numbers. But these are sort of the numbers that you have to memorize for making various calculations when it comes to electrons. So we already talked about the practical range of electrons. Remember, we said that the practical range is the energy divided by 2. So if we're thinking about a 9 MeV beam, the practical range, so the range within which the dose to the patient is actually going to be clinically relevant, is 4.5 centimeters. Beyond 4.5 centimeters, we're not going to see much clinically relevant dose. And so we really don't have to think about using measures to kind of block beyond that dose or beyond that depth. Okay, so the practical range is energy divided by 2, and that is kind of a range of doses that are actually clinically relevant. Think of that as the very tail end of that PDD where the dose finally falls off. That is the practical range. The Dmax is the depth of maximum dose. So the depth of maximum dose, the rule of thumb for this is energy over 5. So let's say we're dealing with a 9 MeV electron. 9 divided by 5 is 1.8. So the maximum dose, if we just shine an electron beam on a patient's surface, the maximum dose is going to be at 1.8 centimeters. Now remember, with electrons, we typically will use bolus to kind of help. There is still an area of buildup when it does come to electrons, and so we'll sometimes use a bolus to get to that, to bring that Dmax more superficial and to get into a therapeutic window quicker. So with the depth of Dmax, remember, it's energy divided by 5, and that's a quick rule of thumb to remember what the depth of Dmax is for any given electron beam. The other two equations that are important to think about are the 90% isodose line and the 80% isodose line. So basically what we're asking is, once we shine on an electron beam on a patient's surface, or if we're using bolus on that bolus surface, at what depth are we going to have 90% of the dose covered, and at what depth is it going to cover with 80% of the dose? So the mnemonic for this is 4 and 3, but in practice, the actual numbers that are used are different. So we say E over 4 for our rule of thumb mnemonic, but it's actually energy divided by 3.2 or 3.3. I typically stick to 3.2. So 9 divided by 3.2 is around 2.8 centimeters. So the 90% isodose line for electrons of 9 MeV energy is going to be around 2.8 centimeters. So what does that tell us? Basically, that helps us to think about the thickness of the tumor that we're treating. If we want, because what we do in electron therapy is when we're doing these clinical setups, we will typically prescribe our dose to the 90% isodose line. So what that means is everything that's covered by 90% isodose line will actually get 100% of the dose. And then we know that we're going to accept 110% hotspot because we're prescribing to the 90% isodose line. So if we are using a 9 MeV beam and we know that 9 divided by 3.2 is 2.8, then whatever we're treating has to be less than 2.8 centimeters thick. And if we're going to use any degree of bolus, so say we're going to use a 0.5 centimeter bolus, then we actually subtract out that 0.5 centimeter bolus and say, okay, well, the depth of whatever we're treating needs to be 2.3 centimeters. And that just allows us to kind of ensure that we're covering everything we need to with the 90% isodose line. The 80% isodose line, I think, is not as clinically relevant because we're not typically prescribing to the 80% isodose line, but it can come up on tests. So again, the mnemonic is energy over 3, but most sources actually use energy divided by 2.8. So if we are asked, what is the 80% isodose line? Like within what depth is going to get 80% of the coverage? It's 9 divided by 2.8, which is around 3.2. And so 3.2 centimeters is the answer. So these rules of thumb are, in theory, straightforward, 5, 4, 3, 2. Remember, think about it as going from the surface to deeper and deeper into the patient. So at the surface or close to the surface, we get our Dmax. So that's energy divided by 5. That's sort of the lowest depth that we're going to get is Dmax. The 90% isodose line is going to be a little bit smaller than our Dmax. It's going to be energy divided by 3.2 to 3.3. The 80% isodose line is going to be energy divided by 2.8. And then the deepest depth is going to be the practical range, which is where the clinically relevant dose just kind of falls off. And that's the tail end of that PDD curve. So the practical range is the energy divided by 2. So 5, 4, 3, 2 helps us to remember that mnemonic, but remember for the 90% and the 80% isodose line, we're actually dividing by 3.2 and 2.8 respectively. Here is just that example of our 9 MeV electron beam written out for reference. Remember that these are very approximate formulas. Typically with electrons, we often will do clinical setups. And so everything is kind of a clinical approximation. So these are not perfect formulas. And, you can talk to your actual physics team to determine the exact numbers for your patient on your machine. But these are just approximate measurements, and these numbers come in handy for exams. And remember that when we divide by these numbers, divided by 5, 3.2, 2.8, and then 2, the answer that we're getting is going to be on the order of centimeters. So the depths that we are calculating are measured in centimeters. There are many other useful formulas when it comes to electrons, and these are also formulas that you probably do need to know for physics board exams. One thing that's very commonly asked is the stopping power of electrons, or how much energy is lost. And a rule of thumb is that electrons lose around 2.33 MeV per centimeter, or an approximation of that is around 2 MeV per centimeter. That's kind of the stopping power, or how much electrons lose as they travel through tissue. So electrons, remember, they lose around 2.33 or 2 MeV per centimeter. So by the time a 9 MeV beam has traveled 1 centimeter into the body, its energy is closer to around 7 MeV. So that's kind of a useful mnemonic to keep in mind, or a useful formula, to keep in mind. Other formulas, so the depth of lateral equilibrium is calculated as the square root of the energy, and the radius of the lateral equilibrium is half the square root of the energy. The radius of the lateral equilibrium, so 0.5 times the square root of the energy, that helps us to determine our margin, so how much margin we want to treat around the tumor based on the energy that we're using. So we kind of use the depth of the tumor to determine what energy we want to use. And then once we know what energy we want to use, we kind of think about how much margin do we want to add on that. So we can think about it and do the math, for forever. In practice, we will often just add kind of a 1.5 to 2.5 centimeter margin using higher margins for higher energies. But if you really want to get nitty gritty and calculate the actual radius of lateral equilibrium, you can use the formula 0.5 times the square root of E to calculate the margin. Although I will say in practice, most often we're going to just use a 2 centimeter margin. Energy over 10 is the formula used to calculate the distance from the tumor edge, so the 90% isodose line, to the field edge, which is our 50% isodose line. Just like for photons at the field edge, we're going to be covering by 50% of the dose. So the energy over 10 kind of calculates the 90% divided, or the distance from the 90% line to the 50% line. That's energy over 10. And then finally, this formula is important, the thickness of a lead shield that we need. So all the formulas we've talked about so far have given us answers in centimeters. The thickness of a lead shield, the answer is in millimeters. So the way we calculate the thickness of a lead shield is we do energy divided by 2 in millimeters, and then we add an extra millimeter buffer. So if we're trying to shield a 9 MeV electron, for example, we would use 4.5 plus 1 millimeter, so 5.5 millimeter lead shield. And it's easy to remember that the unit is in millimeters, because if you think about a block of lead, think about using a 5.5 millimeter lead block versus a 5.5 centimeter lead block. It has to be millimeters, right? So lead is the only one of these formulas that we actually yield an answer that's in millimeters. So the thickness of a lead shield is energy over 2 in millimeters plus 1 millimeter. And then there's another material called cerobend, which is, I believe, made up of a few different materials, and it's also used as a shield. The density of cerobend is different, and so lead is more dense. So we actually multiply the formula for lead thickness, whatever we calculated, we multiply that by 1.2 millimeters to get the answer for cerobend. So say we're using a 5.5 millimeter lead shield. If we wanted to use cerobend instead, we would use a 6.6 millimeter cerobend shield. So these are some other useful formulas that do come up. And this is just here for reference, because all of these are formulas that you need to know for board exams. Before we get into our example case, there's just a few more general principles I want to go over, and just kind of going over various variables that can affect how electrons kind of travel and how those isodose lines look. So one of the things that can impact how the shape of our isodose lines turns out is the energy of the electron beam that we're using. So lower energy electrons are more likely to scatter laterally. And so when we think about the high isodose line constriction, they're not as constricted. The high energy isodose lines are going to kind of splay out laterally because low energy electrons are more likely to scatter laterally. With high energy electrons, the high isodose lines are more likely to be constricted laterally. So the 100%, 90% isodose lines, they're going to be more constricted laterally. And the reason for this is that these higher energy electrons are more likely to travel forward. So they are kind of more forward directed. They're not as likely to travel laterally, and that ends up constricting the high isodose lines. For low energy electrons, by the time we get deep enough to those low isodose levels, the isodose lines start sticking closer together. But for high energy electrons, the low isodose lines are further apart. And that has to do with the kind of range straggling that we talked about also earlier on in this talk. So big takeaways here: for lower energy electrons, the high isodose lines splay out laterally, and the low dose lines end up kind of constricting together. For high energy electrons, these electrons are more likely to travel forward, so we see less lateral movement of those high isodose lines. And then by the time we get to the low isodose lines, there's more lateral expansion, and the isodose lines are further apart due to range straggling. Another factor that affects how our PDD curves look for an electron beam of any given energy is the field size. So this picture on this slide shows an example of a 12 MeV electron beam and the impact of various field sizes. So as you can see in the image, with smaller electron fields, we get a higher skin dose, a shallower depth for our Dmax, and a less steep PDD curve. So the dose kind of tends to fall off more gradually. For the larger field size, we see lower skin dose, a deeper depth of Dmax, and a steeper PDD curve. So the dose falls off more sharply. And this concept, I think, is a little bit more difficult to wrap my head around. But what I basically think about is that as the field size increases, there are more electrons from the outside of the field, so from kind of the periphery of the field, that are being scattered towards the middle. And as those electrons are scattering towards the middle, I think of them as sort of pushing the Dmax deeper into the patient. And as that Dmax gets pushed deeper into the patient, the skin dose actually decreases as well, and we end up with a sharper dose fall off. So for larger electron fields, just remember there's going to be more scatter pushing dose deeper into the patient. So we get less skin dose, we get a deeper depth of Dmax, we get a steeper PDD curve. And then for smaller electron fields, we kind of have the opposite effect. And that effect applies to smaller cutouts too. So if we block an electron beam a lot and have a very small cutout size, that brings our dose closer to the skin surface. So in reality, when you're actually planning out a clinical setup for any patient with electrons, there's usually an electron book in the department, and it's a specific book that's kind of specific to the parameters on a given machine. And it'll kind of tell you what the percent depths are. It kind of is a chart, and it goes through the different percent depth doses for a given energy beam for a range of different field sizes. So it'll sort of tell you, oh, a 10 by 10 versus a 15 by 15 cm field for, say, a 9 MeV electron beam, this is how the depths will differ. So in practice, you can kind of reference that book and make a decision on what to treat based on the measurements that you've taken on the patient. But the formulas and kind of the principles of these things are important to know for board exams. So remember, for larger electron fields, the larger the field, the more kind of lateral contribution we have. So more electrons are scattering from the outside towards the middle of our field, pushing our dose deeper into the patient. That decreases the skin dose, increases the depth of Dmax, and creates a steeper PDD curve. The same principle of electrons kind of moving more laterally applies when we have a beam angle that's not head on for the patient. So say usually we try to aim to have our beam angle coming in perpendicular to the surface of the patient. If we angle that incident beam, so if the beam angle is now no longer entering perpendicular, but it's entering at a slight angle towards the patient, there ends up being more lateral scatter, and as a result, the dose gets pulled closer to the surface. And this effect is sort of amplified with increasing beam energies. So we need to be very, very careful when we are treating a sloped surface, because if we come in at an angle, then by coming in at that given angle, we end up pulling the dose closer to the surface, and that actually increases our surface dose, and the impact of that increases with increasing beam energy. So what we aim to treat a person with electrons with the beam angled perpendicularly to the surface that we are treating. And another term for that is en face, and that comes from, that's a French term, en face, and that basically means that our beam is directed perpendicularly to our treatment area. Here's an example of what that might look like on a hypothetical patient. So say you are treating something along the patient's abdomen, and it's located more laterally in an area where the abdomen is kind of curved. If we just lay the patient flat on the machine and treat that curved surface with the electron beam so that it's kind of at a slant and it's coming in at a slanted angle, that may actually result in under coverage, because the dose is going to be pulled superficially and you'll get less dose to the full depth of the tumor that you're treating. So we don't want to treat at a curved angle. We always try to treat en face whenever possible, meaning that the angle of the electron beam should be perpendicular to the treatment area. And so sometimes that involves moving the patient in either a decubitus position or some other position to kind of make the tumor as horizontal as we can. And then we then angle our gantry so that the electron beam and the head of the machine are kind of shining perpendicularly onto the surface that we are aiming to treat. So again, the reason that as we come in at a slant, the dose gets pulled closer to the surface is just due to more kind of scatter, and more electrons are going to scatter towards the slanted surface, and that just causes there to be a higher dose when we come in at a slant. So it's really important to try and treat en face, and that's basically just French for perpendicular. And it's not always going to be easy, because sometimes we are treating along a curved surface, such as the scalp, or something along the abdomen, or an arm that's kind of thin and it might be curved. So it's very difficult, but we do have to work with our therapists and our physics team to kind of try and find a position. And a lot of it is just kind of it's oftentimes a clinical setup, and a lot of it is just trial and error and trying to find a position that the patient can comfortably hold. And sometimes we have to do the best with what we've got, but we really try to aim for that en face treatment with electrons, meaning that the electrons are coming in perpendicularly to the tumor that we're treating, or whatever area we're treating if it's a benign condition. So at this point, we have talked about some fundamentals of electrons and basic properties that we think about. We've talked about some formulas that are very important for board exams, and some kind of rules of thumb to keep in mind when we're making calculations for our clinical setups. And then we've talked about some additional considerations, so kind of how the distribution of the isodose lines changes with increasing energy. We've talked about how the impact of field size can affect our depth of Dmax, and also the impact of the incoming beam angle. So now that we understand some of these principles, let's actually walk through a sample case and kind of apply some of the things that we've talked about. This sample case is from a paper that was published in 2012 in Practical Radiation Oncology, and it's a really nice case report of a patient that was treated with electron therapy for a cutaneous squamous cell carcinoma. So if you want to read the actual paper and kind of think about some of the considerations that they made for this patient, I would refer you to that paper in Practical Radiation Oncology. It's from 2012, first author, Dr. Reddy. I've just kind of borrowed some pictures from it and kind of used it as a premise to discuss kind of the clinical applications of some of these formulas and considerations we discussed. So the patient in this case report was a 56-year-old gentleman who presented with a 5.5 centimeter ulcerated mass on the side of the face. As you can see from the images, focusing on the left side the image, which is kind of before the radiation therapy, the lesion is overlying the right zygomatic arch. It's extending anteriorly towards the right lateral canthus of the eye. Posteriorly, it goes to the edge of his hairline. The lesion was biopsied, and it was a squamous cell carcinoma. And due to the location and the proximity to the right orbit, this case was deemed inoperable and referred for definitive radiation. On board exams, when you're asked how would you like to treat a patient, you're expected to kind of say the dose that you want to treat to, the target that you're going to be treating, and with which technique you'll be treating the patient. So with skin cancer, we're not going to get into the nitty-gritty details of management of skin cancer, but there are many different techniques that are acceptable. So brachytherapy is acceptable. We can treat with external beam radiotherapy, and that can include electrons. It can use orthovoltage X-ray therapy, which are basically lower energy X-rays, so they also deposit dose more superficially, or we can use our standard high energy photons. All of this just depends on the tumor, what it looks like, what equipment you have at your facility. This patient, as we know, we're talking about Electron, so he was treated with electron therapy. And in terms of dose, we do have many different options for definitive radiotherapy for skin cancer. This patient was treated to a dose of 70 gray in total. And so let's go through kind of the details of the technique. When we're thinking about treating with electrons, and we see the patient in consultation, it's important for us to measure the lesion. The depth of the lesion is going to help us determine what beam energy we want to use. And remember, we typically prescribe to the 90% isodose line. And so the formula for 90% isodose line is energy divided by 3.2 roughly. Keeping that in mind helps us to think about what beam energy we might want to use. We can also think about the length and the width that we want to use to help determine our field size. So we'll actually measure the length and the width of the tumor, and we add a 1.5 to 2.5 centimeter margin around the tumor. And that margin accounts for many things, right? So one of the things that it kind of serves as our PTV margin too, to account for errors in setup. And remember, there's also kind of a radius of lateral equilibrium. And so the formula for that is 0.5 times the square root of the energy. So we can also think about that when we're thinking about how much margin to add around the tumor. The purpose of adding this extra margin is really to compensate for diminished dose that we see around the field edges. Because we know that as we move towards the edge of our treatment field, we're going to be getting 50% of the dose. So we need to kind of compensate for that with an additional margin. When we simulate the patient, many times we will do a clinical setup, meaning that, we're just going to put them directly on the treatment machine, kind of draw out the area we want to treat, calculate and kind of draw out what we want our lead cutout to be like for our cone or that electron applicator, and we go from there. So the simulation, our position is going to vary based on the location of the lesion. So remember, we try to treat the lesion en face. So whatever we have to do to make that happen. We can rotate our gantry as we need to, but we also might need to rotate the patient and have them either lie on their side, lie on their belly, lie on their back. It just depends on where we are treating. For targets that are in the face or in the head and neck region, we will often consider a thermoplastic mask. Even for targets that are on extremities, we can often use a mask to immobilize the joint that is proximal and the joint that is distal to the area that we're treating, just so that we can kind of achieve a reproducible position and make sure that the patient is holding still. So especially for our patient who we're treating something that's on his face, we would consider using a thermoplastic mask to hold the patient still. We do apply a bolus because remember that the surface dose is lower than the depth of maximum dose. And at surface, we are often not yet at that 90% isodose line. So depending on the electron beam energy and where we reach that 90% isodose line, we might need to add a 0.5 cm to 1.5 cm bolus. For targets that are close to areas that we need to protect, such as the eyes in this case, we will utilize a lead shield to prevent our electrons from penetrating deeper into the eyes. Or if we're treating like a lip or a cheek or something like that, we might put a lead shield inside of the mouth or against the gum, for example, to protect our oral mucosa. And then, finally, we draw the shape of the cone. So we decide what we want our lead block to look like to prevent dose from spreading to the outside. So this is all stuff that is really thought about and measured out and considered during simulation. And like I said, oftentimes these are clinical setups, although some physicians, especially in the modern era, might consider using CT-based planning with electrons just so that they can actually have kind of a 3D plan to look at and some people feel better doing kind of CT-based planning even when we're using electrons, but traditionally these were always treated as clinical setups. Now, for our patient, how would we select an appropriate beam energy? So remember, in our example, the lesion measured 5.5 by 5.5 centimeters, and say the thickness was approximately 1 centimeter thick. With our 2 centimeter circumferential margin, our field size then is approximately 8 by 8 centimeters, right? And we will eventually want to determine the adequate margin once we determine our electron energy. So in terms of what electron beam energy should we use? So the 9 MeV beam, the 90% isodose line, is going to be at 2.8 centimeters. And if we use a 0.5 cm bolus, then we're going to be treating to 2.3 centimeters inside of the patient. If we use a 6 MeV beam, the 90% isodose line comes out to 1.9 centimeters. And we might need a larger bolus with the 6 MeV because remember the surface dose will be smaller with 6 MeV. So if we use a thicker bolus, then we end up treating only 0.9 cm inside of the patient. So then we're kind of missing some of that tumor. So again, in practice, you'll refer to the machine-specific electron book, which shows the PDD for different electron beam energies based on field size specific to your machine. But these are just calculations that you can use, and it's really that 90% isodose line calculation that comes in most handy here to help us decide what energy beam we should use. So this case, in the case report, it was actually treated using a 9 MeV electron beam with a 1 centimeter bolus. Now, for this case, remember, we're treating a tumor that's very close to the right eye. And so we can actually think about using a lead shield to minimize our radiation dose to the non-treatment tissue. So lead shields are commonly used when we're treating areas on the face. So for example, in this case, we're going to use a lead shield for the eye. If we're treating something along the lip or the cheek or something like that, we might use a lead shield inside of the mouth to protect the oral cavity. So in this case, we're going to utilize a right eye shield. And remember, the formula for the lead shield thickness is the energy divided by 2 in millimeters plus an additional millimeter for buffer. And an important thing to realize with a lead shield is that if we just put a block of lead inside of a particular cavity, there's going to be some backscatter of electrons on the beam side, and that can actually contribute to increased dose and create an unnecessary hotspot. So we will often use a lead shield that's coated in wax to absorb the backscatter. So this applies to, an eye shield. It also applies to if you're putting a shield, say, on the gums to protect something when you're treating a lip cancer. We always want to use a lead shield that's coated in wax, and the wax should be on the beam side because that's the side where you're going to have backscatter contributing to a hotspot. So this picture shows an example of an eye shield, and you can imagine this is it's like inserting a contact lens, but it's very uncomfortable for patients. So we use an anesthetic eye drop, such as a 0.5% proparacaine drop, before we apply the eye shield, just because that's, undoubtedly uncomfortable for patients. So this is the image that was published in this case report, and it shows the patient with the squamous cell carcinoma close to the right eye, and his setup with a thermoplastic mask over the face. There's an internal eye shield with tape over, and you can see that they drew out a roughly 2 centimeter margin around the tumor, and that is kind of the area that's included in their target volume. And then on top of that, they added a 1 centimeter bolus. So these are, these can be very complex setups, and it's really important to think about different variables that might be hard to reproduce, because these can be difficult and very time consuming for the therapists on the treatment table to recreate. So we want to, from the get-go, kind of think about the different variables that might affect our setup and try to make it as streamlined as possible for the therapists. This image here then is just a stock image online. It's not from the case report, but it shows a nice example of what that cone and cutout might look like when we're treating a patient with electrons, and how we really try to get that cone very close to the patient's surface to prevent electrons from scattering in the air. That brings us to an end of everything I wanted to talk about, hopefully walking through that case report and actually thinking about how we would apply some of those principles that we talked about earlier on, how that actually applies when we're treating a patient. Hopefully that helps. So in summary, just a few points I'd like to recap. Remember, electrons are ideal for treating superficial targets because they have a very low mass, and so they do not penetrate very deep into the tissue. Remember that as we increase the beam energy and as we increase our field size, we're going to have more forward movement of electrons, and that's going to increase our depth of Dmax. When we are using a slanted treatment surface and we're not necessarily treating en face, that's actually going to cause more lateral scatter, pulling our dose closer to the patient's surface, and that decreases our depth of Dmax. And then we do need to consider the field size and the energy as well. So remember that higher energy beams are going to travel more forward, and so our higher isodose lines are going to start to pinch in. And so as we use a higher energy beam, we need to use a greater margin, and we can remember that half times the square root of the energy to think about how much margin we need to use. Typically, you're not wrong if you just say a 2 centimeter margin on the tumor, but remember, as our beam energy gets higher, we typically need to increase our margins as well. The most important point, I think, and I tried to emphasize this earlier too, and I confess it was hard for me to learn this, and it took a lot of time. But I think the most important thing to take away for electrons is what happens to the surface dose and what happens to the depth of Dmax with different energies. So remember that for electrons, both the surface dose and the depth of Dmax are going to be greater for higher energies. This is in contrast to photons, where the depth of Dmax is greater for higher energies, but the surface dose is actually greater for lower energies. So I think that is the biggest takeaway, and if you understand why that makes sense, like I said, I think that is more than half the battle. I hope that this was a useful review on properties of electron beams. Good luck if you're studying for the physics boards, and thank you so much for your time and attention.